Hey everyone, thank you for joining us. Today, you are in the right place if you have joined our STI Masterclass virtual training on the rising tide of STIs. This is hosted by HCET with presenter Dr. Jessica Dalby today. I'm super excited. So my name is Adele White. I'm a project manager at Healthcare Education and Training, and I'll be your MC for today. So before we get started, I'm just going to briefly introduce you to Healthcare Education and Training, and I'm going to call it HCET from now on, just for short. So HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And we are an organization of passionate people who really are proactive in our belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. So this webinar has closed captions available. To enable them on your screen, click Live Transcript, and then you can click Show Subtitle. And you can change the settings by clicking Subtitle Settings. So throughout the presentation, we encourage you to send your questions as you think of them via the question and answer. So it says a little Q&A box at the bottom of your screen. So when you want to submit a question, just hover over the main screen, select the Q&A icon at the bottom, and then once you click on that, a little box should appear where you can write your question. And you can send a question at any time. It doesn't disturb the webinar. And then please send it through the Q&A function because the chat doesn't work in this webinar format. And you can also send questions anonymously if you choose. We will hold all questions to the end so we can answer them all at once because we know some people will have the same questions as well. So for more information and to keep up with HCET events, you can follow us on social media. We have some of them listed here, or our website at hcet.org. And you can also check out our other training and professional development opportunities by visiting our virtual learning website at learn.hcet.org. Just after review a couple housekeeping items. So after this training is complete, you'll be sent a link to an event evaluation. This is really, really helpful to us. Thank you in advance for your feedback. It helps to improve our marketing and trainings in the future. Archived presentations and a list of upcoming events can be viewed on our website. So that's hcet.org. If you have any technical difficulties during this presentation, contact me at my email, and I will make sure to get to Jen, who you'll see her picture on the screen. She's helping us behind the scenes in this webinar today. Thank you, Jen. So if you are applying for nursing contact hours for this training, a couple things to know. So to receive nursing contact hours for this event, a participant must attend the entire webinar, return to completed participant evaluation and post-test, which is the link you'll receive after this training, and complete the nursing contact hours form and email it to Kelly Bradford. And she can be reached at kbradford@hcet.org, and you'll see her email right on the screen. Just a little financial disclosure. No one with the ability to control the content of this activity has relevant financial relationships to disclose. So now all the housekeeping is done. I'm super excited to introduce to you our presenter for today. Dr. Dalby earned her medical degree in 2008 from the Baylor College of Medicine in Houston, Texas. And she completed a family medicine residency at the University of Wisconsin-Madison in 2011, so right here in Wisconsin. She went on to complete an academic fellowship within the UW program prior to joining the faculty there at 2012. So in 2017, she became the medical consultant for sexually transmitted diseases within the City of Milwaukee Health Department. So some of you may know this large urban health department faces high rates of sexually transmitted diseases and sharp resurgence of syphilis recently. Dr. Dalby is currently developing syphilis-specific continuing medical education to address the Wisconsin syphilis resurgence in collaboration with the UW-Madison Interprofessional Continuing Education Partnership. Her other teaching and academic interests include reproductive health, including prenatal care and obstetrics. And I'm super excited to turn things over to you, Dr. Dalby.
Thank you, Adele. All right, so again, my name is Jess Dalby, and today in this first masterclass session, we're really going to be talking about the epidemiology of sexually transmitted infections. I will just say I often say that I am a family physician by day and a syphilis expert by night. So we'll get into that. So in terms of just setting up the masterclass schedule, again, today we're really going to be talking about epidemiology of STIs in the nation and in Wisconsin specifically. Our next update is going to really focus on testing and treatment. And our final update is going to be a focus on caring for special populations. As already reviewed, I have no actual or potential conflicts of interest. So learning objectives for today, again, we're going to highlight trends in STI incidents, both nationally and at the local level. We're going to talk about screening recommendations for STIs and at-risk populations. And we're going to describe the implications of the current bioacillin shortage and how that applies to the treatment of syphilis, and talk about best practices in collaborating with our health departments. I'm going to highlight today with intermittent discussion of a case. So we're going to focus today on what we are starting to see much too often. So Liv is a 29-year-old woman who presents to the ER for left arm cellulitis concerns. She has active substance use disorder and injects opioids. She has not had her menses in several months and thinks she may be pregnant. So we'll start with just the big picture, the national landscape. The most recent data in the US is from 2021, and as of 2021, chlamydia cases had kind of stagnated, but continue to be very prevalent, over 1.5 million cases of chlamydia. Gonorrhea cases continue to climb steadily, and there's been about a 30% increase since 2017. And syphilis cases continue to make marked jumps. So you can see here that in the past 5 years of reporting that syphilis cases across the country had increased by 75%, and there had been a 200% increase in cases of congenital syphilis. Just historically, it's interesting to look back. Chlamydia actually has only been a reportable disease since 1995. Kind of shockingly to me, I learned that while I was preparing this. And actually, chlamydia was not reportable in all 50 states until 2000. So we have seen steady increases in chlamydia rates beginning through the time of collection. I want to point out that in the 90s is when nucleic acid amplification testing became available, which is a much more sensitive way to detect chlamydia. And so as we see these increases, they're in part due to more sensitive tests. They're also due to actually just increased screening of asymptomatic people, and also improved reporting practices. So all of those things contribute to this kind of rising rates. Now, all of a sudden here in 2020, you see a dip. So, COVID and our understanding of what's going on with STI epidemiology, it's really shaken things up. So obviously we saw, clinic closures, decreased access to care, also just diversion of public health resources in tracking and decreased resources within clinics and places who are supposed to be doing the reporting. So I think, the data gets a little shaky starting in 2020. But you can see again, dip here with some rebound increase. Again, we'll look at this a little bit more, but we see, especially when people, since chlamydia is often detected in asymptomatic people, again, we see a bigger dip with the start of the COVID pandemic. When we look at the last 10 years, you can see kind of generally increasing rates across the US over the past 10 years, looking at this map here. And when we break it down, so this is the 2021 data broken down by sex and age group. And so you can see we have much higher rates reported in females. Again, females tend to present to care more often, especially when they're asymptomatic for testing. But again, chlamydia primarily affects the younger age group, so under the age of 24. And again, we detect more chlamydia in females, but also that's who's presenting more often for care. We're also going to talk today about the differences in racial and ethnic groups. The highlight here is really to as a reminder, race and ethnicity are social constructs. Obviously, there's no biologic predisposition to sexually transmitted infections, but highlighting these differences is really important to highlight pervasive systemic racism and how it affects different communities. So you can see the Black and Native populations have the highest rates of chlamydia noted in the US. If we jump over to gonorrhea, you can see here, like historically, gonorrhea has been a nationally notifiable, recognizable condition since the 1940s. That initial decrease has to do with widespread use of penicillin that became available at that time. You see increases, a rapid increase in the 60s and 70s. Beyond just what was going on socially at that time, actually there was much better testing that came about at that time. So that's where culture medium was developed that greatly improved diagnosis, particularly in women. And so we just have much better testing available then. Again, we see as we recognize it more and are treating it more, we see decreased rates. But then recently, over the past 10 years, you can see those rates are going up again. Again, this is the map. You can see the highlighted differences as the colors kind of fade to a dark blue and as incidence increases over the past 10 years throughout the country. And highlighting here is the difference between age and sex. So again, gonorrhea also predominantly affects a younger age group, so 24 and under being the most heavily affected. But there's a more equal distribution here among men and women, in part because, again, gonorrhea, while it can be asymptomatic, it can often be symptomatic, especially in men. Highlighting, once again, racial disparities, again, Black and Native populations being most highly affected. And no talk would be complete without mentioning, the resurgence or the surge of drug-resistant gonorrhea. Over the course of time, every antibiotic that we have been treating gonorrhea with, we've seen resistance emerge from gonorrhea. Currently in Wisconsin, we have a collaboration between the state health department and some STI clinics in the Milwaukee area to actively monitor through using culture antibiotic sensitivity of gonorrhea. Over the last several years, we have seen some intermittent and sporadic cases of cephalosporin, decreased susceptibility, no outright resistance. But certainly nationally and internationally, you hear about these cases popping up. And I do think, it is our job to be preparing systems to respond to potentially increasing cases of drug-resistant gonorrhea. And currently we don't have another treatment option. There are some new antibiotics in the pipeline, but really, ceftriaxone is currently our last and currently best treatment option. So things that providers can be doing, again, is following CDC screening and treatment guidelines, the newest guidelines emphasizing monotherapy with ceftriaxone, 500 milligram injection, or 1,000 milligrams if people are over 300 pounds. We need to be reporting treatment failures or suspect treatment failures to the health department. And really, this is important, again, because while we're doing some monitoring in the Milwaukee area, emergence of drug-resistant gonorrhea could happen anywhere at any time. So for providers throughout Wisconsin seeing cases of suspect treatment failure, it's really important to report that to the local public health department so we can connect you with the ability to offer culture for those clients, to see really, is there antibiotic resistance or is this reinfection? And again, this is another role for preventing reinfection by notifying and treating partners. So that's where collaboration with public health is going to be really important. And also tools like expedited partner therapy when appropriate. So now we're going to jump into syphilis. So syphilis has also been reportable since the 40s. And again, you see this very steep decline with the advent of penicillin. And this isn't just treating syphilis with penicillin. It was basically the widespread use of penicillin for strep throat and every other type of infection that, incidentally cured a lot of syphilis at that time too. So we see, huge decreases in syphilis over the first 50 years of reporting. Then in the 90s, we really did see another resurgence. And, here you can see, that was really overlying with the crack cocaine epidemic that was happening at that time. We then see a sharp decrease in syphilis cases for the next couple of decades, and I would say most clinicians who are practicing today have only known low levels of syphilis, which makes us less adept at managing syphilis. But recently, as we'll highlight here, we are starting to see again increasing case reports of syphilis, and these case reports of syphilis actually are increasing quite rapidly. So just between 2020 to 2021, the rates of reported syphilis increased by 30% in the US. And here again is a map showing the transition to dark blue of much of the country in terms of syphilis rates. So again, much higher rates over the past 10 years. Syphilis, interestingly, affects a slightly older age group. So you can see here that kind of the 25 to 35-year-old age group is the age group that's most affected. Syphilis has long afflicted men at a higher rate, and especially same gender loving men or men who have sex with men. So we see, again, a much higher rate in that population. But as we'll highlight here, we have actually seen a very sharp increase in syphilis among women nationally and in Wisconsin as well. And this kind of highlights here, so you see that starting in 2020, we really saw a huge jump in the number of cases that were affecting women. Similarly, in terms of race and ethnic disparities, again, here you can see that when we started in 2020, we started to see a very rapid rise of syphilis. That heavily impacted the Native population, and was also markedly increased among the Black community as well. Something that's interesting that I'd like to highlight here is that with this rapid increase in syphilis, STI clinics have seen a slight increase in syphilis cases, but it's really the non-STI clinics across the country where they're seeing the largest increases in patients presenting. And so again, clinicians who may not commonly be thinking about syphilis are now seeing a lot of syphilis. When we look at, as we see case rates increase, I'd like to highlight here, the black line highlights what's happening in terms of case rates in women. And you can see, again, that sharp increase starting in 2020. And as we see increases in women of reproductive age, we are seeing congenital syphilis increases, as you can see here in the blue boxes. Between 2020 and 2021, the number of congenital syphilis cases increased again by 30%. And in that time period, there was actually a 50% increase in the rates of primary and secondary syphilis among women of reproductive age. So in 2021, there was almost 3,000 cases of congenital syphilis in the US. 10 years ago in 2012, there was just over 300 cases. So again, this is a market increase over the past 10 years. And this is a good time to highlight that, congenital syphilis, each case of congenital syphilis is really a sentinel event because congenital syphilis is preventable. So here you can see on the map of the US that in terms of all the STIs, this is where we really see the largest shift with higher rates is in syphilis. And this particular graph is again focused on syphilis in women of reproductive age. And so you can see at this point, practically the entire country is now facing higher rates of syphilis in women of reproductive age. And with that, again, goes corresponding increases in congenital syphilis across the US. When I first started at the health department in 2017, I think that was a notable year for congenital syphilis. There was 3 cases. We'll talk more, but as of 2022, we saw almost 30 cases in Wisconsin. So this has been a market increase. There is significant overlap in terms of women with syphilis and drug-related risk factors. So about 35% of women with syphilis report sex while intoxicated or high. About 10% involve sex with people who inject drugs, and slightly less than 10% involve a history of exchanging sex for drugs or money. Again, racial disparities are most marked in the Native population, also high among the Black community. Again, emphasizing all the confluence of systemic racism that affects these communities. When we look at case rates of congenital syphilis, specifically, again, highest in the Native population, the rate, but overall cases highest in the Black community just based on population differences. So again, you can see both Black and Hispanic people account for the lion's share of congenital syphilis cases, although they don't make up the lion's share of the population. So going back to our case scenario, so on exam in the emergency room, Liv has a temperature of 100.6. Her left arm is warm with a large red area surrounding a recent injection site. On abdominal exam, her uterine fundus is palpable at the level of the umbilicus, and a Doppler detects fetal heart tones at 145. So for those of you who are not practicing OB, typically, by the time the uterus can be felt at the umbilicus, that somebody's around 20 weeks at that point. So the resident physician caring for Liv in the ER notices she has not had any prenatal visits and adds HIV and syphilis testing to her lab work today. So just a few notes on congenital syphilis that come from national data. This is kind of what happens in terms of outcomes for congenital syphilis. And what I want to point out here is that while infant death and stillbirth are, of course, the most severe and most notable outcomes of congenital syphilis, they're not the majority, although, again, several hundred cases in 2021. A little less than half of infants are born alive, but with signs or symptoms of congenital syphilis. However, the really important take home from this slide is this large margin in dark green of those infants that are born alive, but have no documented signs or symptoms of congenital syphilis. So those infants are actually only detected and only known to have congenital syphilis because of the maternal testing that was done. If we're not testing, we're missing those cases. And we know that congenital syphilis can have significant long-term sequelae. So even those who don't have signs and symptoms at birth can go on to develop late manifestations that often appear after 2 years of age. That includes neurodevelopmental delay, blindness, deafness, and musculoskeletal deformity. When we think about missed opportunities. So at a national level, again, there was about 3,000 cases of congenital syphilis in 2021. Over half of these cases showed missed opportunities during prenatal care. So in the large purple bar, those were people who were diagnosed with syphilis but did not receive adequate treatment. In the bright pink, we see those who had an initial negative test, but then became infected with syphilis during the pregnancy, and it was not identified in time. In orange, those were the people who actually were engaged in prenatal care, but were never tested for syphilis. And so again, over half of cases from national data were missed opportunities. Now, the dark green bar at the top are those, almost in 42% of women who had no timely prenatal care and no syphilis testing. Again, many of those people also have comorbid substance use disorders, and we know that in states that criminalize substance use disorder in pregnancy, that pregnant people are less likely to engage in prenatal care, less likely to engage in substance use treatment. And in this case, we're also seeing that they don't get tested for syphilis or treated when they need to. So in states like Wisconsin that has Act 292, the Unborn Child Protection Act, which criminalizes substance use in pregnancy, again, we see a lot of people falling through the cracks, not accessing prenatal care and not having this testing and opportunities for prevention. So what's the recommendation for syphilis screening? So just as a review, the USPSTF says that we should be screening for syphilis in anybody at risk for infection. And interestingly, their list of people at risk include men who have sex with men, people with HIV or other STIs, people using drugs, people who have a history of incarceration, sex work, or military service was a new one for me when I reviewed this. However, it's really important that clinicians are aware of how common syphilis infection is in their community, because again, that also increases the risk and who we should be screening. They also support that all pregnant women should be tested for syphilis as early as possible when they first present to care, and that if somebody has not received prenatal care prior to delivery, they should be tested at the time of delivery. The CDC notes that syphilis screening in pregnancy should be done 3 times during pregnancy, both at the first prenatal visit or upon pregnancy diagnosis, a second time at 28 to 32 weeks, and again at the time of delivery. And they recommend screening 3 times during pregnancy for those with risk factors, but also in communities with high rates of syphilis. So what defines a high rate of syphilis in our community? Let's talk a little bit more about what's going on in Wisconsin to help define that. We'll jump back to talking about chlamydia. In general, there's a lot of chlamydia out there. There hasn't been much of a change over the past 10 years. Again, we can see here over the past 10 years, rates are mostly stagnant, slightly increased, with, again, a corresponding decrease during the pandemic, which makes the data a little bit harder to interpret over the past couple of years because of decreased opportunities for screening, people less likely to present for care during that time. In Wisconsin, we also see the same racial disparities that we see nationally, with the Black and Native population having higher rates. And notably, in a lot of this data, we see actually, while rates among many communities, Black and white, have kind of stagnated for chlamydia, we are seeing increasing rates in the Native population. Gonorrhea, we see a little bit more. Similar to national data, we're seeing a little bit more throughout the state. And again, here you can see rates have roughly a little bit more than doubled in the past decade. And you can see here again, starting in 2020, we have slightly decreasing numbers, whether that's a true decrease or impacted by reporting difficulties or decreased opportunities for testing. It's, again, this data has to be taken with a grain of salt. And again, similar racial disparities, again, here with higher rates among the Black and Native population. So the big news here is talking about syphilis nationally and in Wisconsin. So again, markedly, you can see the numbers here that starting in 2020 with the onset of the pandemic, we see a huge increase. Syphilis rates between 2020 and 2021 roughly doubled. And then between 2021 to 2022, we saw another 20% increase beyond that. Over the past decade, we have seen syphilis become much more prevalent across Wisconsin counties. So you can see that as of 2022, there was only about 10 counties that didn't have syphilis cases reported in 2022. So again, at this point, we see syphilis cases throughout Wisconsin. And while most syphilis is concentrated in southeastern Wisconsin, again, throughout Wisconsin, we are seeing these case numbers increase. So western and northern Wisconsin, have seen case numbers triple, while, northeastern and southeastern Wisconsin have seen rates slightly more than double. We see case numbers increasing really throughout Wisconsin. Racial disparities in syphilis also very significant, with, again, the onset of the pandemic. And, I think as we think about how COVID disproportionately impacted different racial and ethnic groups, we see also syphilis markedly affecting here the Black and Native communities as well. In terms of syphilis among childbearing age women in Wisconsin, we can see that over the past 5 years, in 2018, there were about 80 cases of syphilis in women between the ages of 15 and 44, whereas by 2022, we see that number has jumped to 520. We also then see a corresponding increase in syphilis among pregnant women. So in 2022, there was 111 cases of syphilis in pregnant women, and that has led to us seeing increased rates of congenital syphilis. So again, in 2022, almost 30 cases of congenital syphilis. And again, for the past decade prior to this, 1 or possibly 2 cases was the norm. And we are just seeing, again, in the last several years, market increases in congenital syphilis. This just highlights those numbers one more time, showing that congenital syphilis has increased about 2,800% over the past several years. Milwaukee County accounts for most of the congenital syphilis seen in Wisconsin, but again, there have been several cases in different parts of Wisconsin, and I would expect that we will continue to see these numbers increase as we see syphilis increase in women across Wisconsin. So back to our case scenario. So Liv gets treated for cellulitis and discharged from the ER. The next day, her treponemal EIA returns positive along with her reflex RPR titer, which is 1 to 32. Her listed phone number is disconnected. The public health department is notified of her positive test. So what is happening at the health department? So the disease investigation specialist received notification of the positive test result. They open a case for investigation, noting that she has not been treated. Case review does show she was actually previously treated for syphilis of unknown duration 10 months ago and was given 28 days of doxycycline due to a reported penicillin allergy. Her RPR at that time was 1 to 16. However, she had no follow-up titers. So we don't know whether she was able to take the doxycycline. We don't know whether she was adequately treated in the past. So after trying to get a hold of her, the health department finally makes contact with her over Facebook and convinces her to present to the health department with her partner. She is a thorough exam to help stage her syphilis. On exam, she has no lesions. Her cranial nerve exams are normal. She's not having any vision or hearing changes. She has a full complement of STI tests done at that time. Her RPR titer is also repeated at this time just to give us a new baseline to monitor our treatment efficacy. We discuss her penicillin allergy in detail. She had a rash as a child after amoxicillin and did not require treatment, but has not had penicillin since. Just a brief foray here into talking about penicillin allergy. And there's a nice summary in the new 2021 CDC treatment guidelines. Penicillin allergy is reported in up to about 10% of the US population. However, the rate of true allergy is quite a bit lower, somewhere between 1 and 6%. Interestingly, 80% of patients who've had a true allergic reaction to penicillin actually lose that sensitivity after about 10 years. As a reminder, penicillin is recommended for all stages of syphilis, and there are no proven alternatives in the setting of neurosyphilis or congenital syphilis or syphilis during pregnancy. So it is really important that we think about when we can safely use penicillin. There are some defined low-risk histories in patients who report penicillin allergy. And so our patient who had a rash as a child, we would need a little bit more detail about, was it delayed onset? Was it immediately? Was there any hives or symptoms that would pruritus, things that would suggest hives, swelling, things like that we'd want to know. But we can, there's a tool that we use at the Milwaukee Health Department that's called the PenFast score, which evaluates what's the risk of a true penicillin allergy. And it really just bases this on 3 questions. Did the allergy event occur 5 or fewer years ago? Was there anaphylaxis, angioedema, or a severe cutaneous reaction? And was treatment required? Many of the patients that we see have actually a 0 score for that. And in this validated scoring tool, people who scored a 0, their risk of having a positive penicillin skin test was less than 1%. So in our case at the health department, Liv has a PenFast score of 0. She's deemed low risk for true allergy. So she's given an oral amoxicillin challenge. After half an hour, when she has no reaction, she's then treated with penicillin G benzathine, which is bicillin long acting. She's asked to return in 7 days for a second dose. Her partner undergoes evaluation and testing as well, and he's treated as a contact that day. He's given a 2-week course of doxycycline because of the current shortage of penicillin G benzathine. Liv and her partner are connected to prenatal care, doula support, and medication-assisted treatment for opioid use disorder. Her RPR on the day of treatment returns 1 to 64. So just a couple notes. Currently there is a shortage of penicillin G benzathine in most of our areas of care. We should be seeing notices that we should be reserving penicillin G for the treatment of syphilis. I've stopped giving it to people who have, strep throat, who, are going to struggle to take medications at urgent care. Like, we're really reserving this for our patients with syphilis. And as the shortage continues, we also probably need to prioritize pregnant women and infants for benzathine G penicillin. Right now, they're anticipating the shortage will probably not resolve until April of next year. So again, we're seeing right now a time of heightened cases of syphilis and dealing with this penicillin G shortage. I will say that currently at the Milwaukee Health Department, we have a fairly robust supply, although we're not, we're getting trickling supplies of penicillin G. So again, in general, we are treating people who we think can be adherent and are appropriate for doxycycline with doxycycline, but we're still being fairly liberal with our use of penicillin G benzathine. The alternative treatment for syphilis in people who are not pregnant is doxycycline. If it's early syphilis, again, less than 12 months duration, that's going to be 14 days of doxycycline. If it's unknown duration or more than 12 months since somebody was infected, that would be a 28-day course. So just to conclude our case, upon admission for labor and delivery 4 months later, Liv's RPR is 1 to 32. So it was 1 to 64, now it's 1 to 32. She has been on buprenorphine and does not endorse new sexual contacts or use of injectable drugs. She has a normal vaginal delivery of a baby girl. Her newborn has an RPR of 1 to 16. And does not have any exam findings. So the baby in the situation is considered to be less likely to have congenital syphilis, since the mother in this case was treated adequately more than 4 weeks prior to delivery. However, because they're not certain about follow-up for this baby, she does receive a single dose of IM penicillin G benzathine. In this situation, though, because we're going to end on a positive note, the baby follows up at her well-child checks at 2, 4, and 6 months, and RPR titers trend down 1 to 4, 1 to 2, and then become non-reactive by 6 months. Again, diagnosing congenital syphilis can be really difficult because maternal antibodies pass through the placenta, and so a newborn's RPR is often detectable even if they don't actually have congenital syphilis because of that passive antibody transfer. In the case of passive antibody transfer, those that RPR level should be non-reactive by 6 months. But again, that can make the newborn evaluation and interpretation difficult. So just to summarize the key points from the epidemiology today, again, chlamydia continues to be a very prevalent sexually transmitted infection, especially in those under the age of 25, and a screening is important. Again, universally recommended on a yearly basis for those under the age of 25. And for anybody with risk factors beyond that age group. Gonorrhea rates continue to increase, and there are concerns nationally and locally for drug resistance. So be on the lookout for suspected treatment failures and coordinate with your local health department for any concerns. Currently, the Milwaukee Health Department lab is our center of excellence for antibiotic susceptibility testing. So if you have a case of suspected treatment failure, through contacting the local health department, the goal is to get the culture collection kits that are needed from the Milwaukee Health Department and have that testing done to see if this could be the emergence of, again, drug-resistant gonorrhea in cases of suspect treatment failure. And finally, syphilis rates are skyrocketing. We should be screening often, especially in pregnant women. Signs and symptoms are crucial for identifying the stage of disease, and collaborating with public health for evaluation, treatment, and contact tracing is so important. Syphilis is one of the few STIs where contact tracing, again, prevents disease. You have this window between infection, where somebody becomes infected until they become infective. So there's a window in which you can treat contacts and prevent the spread of syphilis. And so public health is crucial in limiting spread of syphilis. So just in terms of helpful resources, so again, especially as we see more clinicians starting to come into contact with cases of syphilis, people don't always have all of the background knowledge that they need. Syphilis, again, has been fairly rare until now, where it's really becoming much more common. And it's complicated. So, if you were feeling lost today during our, syphilis case, I would say, that would be a common experience. Syphilis is hard. It took me actually a couple years working with the health department and thinking about syphilis cases regularly to feel really confident in this management. So, again, our public health departments are people we have our disease investigation specialists. These are people who are really thinking about syphilis on a regular basis and are really experts in recommending management and treatment, and again, also helping to do contact tracing and partner treatment. So working closely with public health is imperative when it comes to syphilis. So these are, again, different public health contacts depending on where you're practicing. And I'd also like to highlight some great resources. So there is a national network of STD clinical prevention and training centers that runs a clinical consultation service that's web-based. You can submit a question about difficult cases, and they are fantastic about getting back to you. Our regional center is out of St. Louis. And so they have docs in St. Louis that staff this line and promptly respond with management advice for difficult questions. There's also, again, the 2021 STI treatment guidelines, and the Milwaukee Health Department has put out a syphilis FAQ, which can be quite helpful as well in the diagnosis and management of syphilis. Additionally, this was mentioned earlier, but if you're confused by syphilis training, if you're confused by syphilis, you're joining your cohort of peers, like most people are. The testing is difficult. The interpretation of the algorithms can be tricky. So I would love to refer you to these self-directed CME courses that are available for clinicians practicing in primary care and prenatal care and in newborn care. The emergency medicine module is kind of next on the docket to launch, but so far right now we have the first 3 are currently available. They have both continuing medical education credits, but also there's continuing credits for advanced practitioners as well. And so again, I would, for needs for more syphilis training, this is a great kind of case-based modules that can offer that. So again, just to review, next time we'll be talking more on testing and treatment, and then have a final seminar on caring for special populations. But that's what I have for today. So I would love to hear any questions.
Thank you so much, Dr. Dalby. I learned so much from that. Thank you so much. And I know we do have some questions coming in, so I'll give y'all just like a couple minutes to type in any other questions you have. And I will just remind all of you, while people are submitting their questions, to get your nursing contact hours, you attend the entire webinar, complete the nursing contact hour form, and email it to my coworker Kelly at kbradford@hcet.org. And yeah, you can see the little circle on the screen is just reminding you where the Q&A button is. Let's see, let me go to some of our questions. Oh, got a great question already. How exactly does one confirm a gonorrhea treatment failure? Good question.
Yeah, so it starts with just being suspicious, right? So I would say that most of the time when somebody presents with persistent so generally we suspect treatment failure if somebody has symptoms more than 3 to 5 days after being treated with an appropriate regimen. So again, persistent symptoms would be one thing, or for people who come back for follow-up testing and have persistent positive testing and deny any further sexual contact. So often when we're doing follow-up and rescreening somebody or retesting somebody who's not having symptoms, if their test is positive again, most commonly that's going to be reinfection, but occasionally we see people who really say they haven't had any sexual contact, and then we have to be suspicious. Could this be treatment failure? Typically, the question is, when we're using really sensitive tests like the nucleic acid amplification test, the NAT test for gonorrhea, it's a really sensitive test, and depending on how soon you test after treatment, you can sometimes get a false positive just from detecting dead organism DNA. So typically, from the rectum or penis or vagina, the NAT test should clear within about 7 days. So if you've treated somebody and they are not still having symptoms, or even if they are still having symptoms, you really don't want to repeat a NAT test within that first 7 days because it doesn't give you much more information. If somebody's having persistent symptoms, you really need a culture to confirm that. Culture is not widely available in many of our practices, and that's why the Milwaukee Health Department lab, which does do cultures routinely for surveillance, is also serving as a regional referral site for providers throughout the state of Wisconsin. And that can be coordinated by contacting your public health department or contacting the state public health department to get that testing availability. So when we culture gonorrhea, we're then able to find out what's the antibiotic susceptibility pattern.
Thank you for that question and for the answer. And I know I can't share things in the chat here, but the things that you just went through, Dr. Dalby, if you Google CDC antibiotic resistant gonorrhea, a lot of the things that she just mentioned are like laid out in a very easy to understand treatment where, you know, she talked about test of cure, for example, and when you should do that if the patient is still having symptoms. Good question.
And actually, I'll just highlight that in the new 2021 STI guidelines, they now recommend that everybody who has pharyngeal gonorrhea return for test of cure about 2 weeks after treatment. And that's because there's a higher chance, you know, it's harder to penetrate the tissue of the pharynx with antibiotics, and there's also, you know, a lot of other bacteria here. So Neisseria meningitidis is a common commensal pathogen in the pharynx, and so and gonorrhea is really good at exchanging DNA and you know, evolving these things. So again, they now recommend in the new guidelines that anybody who's treated for pharyngeal gonorrhea does have a test of cure, which again, I didn't mention this before, but you know, it takes about 7 days to clear NAT tests from the vagina, penis, and rectum, but the pharynx takes a little bit longer. So actually, really in the pharynx, you want to wait really probably closer to 2 weeks or sometime after 14 days to do that test of cure so that you don't have as many false positives.
Thank you. That's helpful. I know in the past, and you can tell me whether this is currently true, like let's say a patient was diagnosed with gonorrhea and treated. Are they still recommending that that patient comes back and is tested again in 3 months?
Correct.
Right.
Yeah. So that is still the recommendation, to test for reinfection in anybody with an STI 3 months later.
Cool. Let me see. It looks like we have another question popping up. Oh no, that's the one from before.
Okay.
One question I have that other people might be wondering as well is, so currently the recommendations are to test any pregnant person with syphilis. Do we know how often that's being done? Has that been the recommendation forever? I'm just curious how often that actually happens.
Yeah, you know, so it's interesting. Wisconsin is one of only 4 states that doesn't have legally mandated syphilis testing. So many states have put into law that you have to test for syphilis, you know, as when somebody enters prenatal care. Some states have it, about 20 states have additional laws that say you have to test for syphilis both at the start and at delivery, or you know, at that midway point at 28 to 32 weeks. So, but Wisconsin has no such legal precedent. So, you know, I would say since I've been in practice, I feel like we've done a pretty good job screening everybody, you know, for syphilis at with the first prenatal labs that we do. I do feel like that's been pretty routine, but I would say, you know, the recommendation to screen 3 times in pregnancy came out with the 2021 guidelines, that they said we really, you know, we're seeing increased rates. We really need to be screening more often. But you know, the guidelines don't define like what is a high risk community. And you know, just tracking the data in Wisconsin, you know, what I would say is that again, we are seeing rapid increases in syphilis in women of reproductive age across Wisconsin. And, you know, recommendations, if we were doing county level recommendations, you know, they are changing every year as we see this increase happening. So I would really advocate that we go to universal screening 3 times during pregnancy at this point throughout Wisconsin. for several reasons. One, because when we advocate for practice change, it takes time to actually be implemented. And so if we're going to stay ahead of this and make a difference, it needs to be now. Also, because just in general, we do a pretty terrible job asking all the right questions, especially if, somebody's coming in labor. It's hard to ask in that moment, about all their sexual risk factors. So I would say, but even, among people, I would say, as clinicians, we often have some biases that affect who we ask and what we ask. And I think there are some natural biases when it comes to pregnant women, that they're pregnant, so they're monogamous, or, so we have some natural biases that prevent us asking the right questions about who's at risk as well. So again, as we see increasing rates, this is really the time to go to universal screening during pregnancy at 3 time points.
Thank you so much. Yeah, I agree. You heard it here, all of us. Please advocate for universal testing with whatever power you can.
And I do think that, just a few things we should expect. I think DHS is currently, working on some updated guidance that is going to promote that increased screening, which will be helpful. And also I wanted to say that Wisconsin DHS is also currently working on their public facing website and documents for drug resistant gonorrhea, and making sure how, the workflows for who to suspect treatment failure in, and how to get the follow-up testing that's needed.
That's wonderful. Thank you. I'll wait just a couple seconds to see if any more questions come in, but in the meantime, I'll remind you all, and Dr. Dalby put this on her last slide as well, that the next 2 virtual trainings in this series are coming up. Jen, if you wouldn't mind advancing the slide, just one. I think I have the dates listed. Yeah, so just like Dr. Dalby shared on her slide, they're Tuesday, October 17th, the same time, Tuesday, November 14th, the same time as the next 2 in this series. And watch your inbox for these event announcements. Like this one, you'll get an event announcement where you're able to have a link that you register with, and then a day or 2 before the actual training, you get event details, and then you click on join webinar to actually join it. So that will be something that we'll send out to everyone who was at this webinar today. And then if you enjoyed today's presentation and you'd like to continue looking at more of our learnings, they're free. You can go to learn.hcet.org, and then there's new opportunities being uploaded all the time. And this recording will be available on our YouTube channel. And how you get to that is you go to hcet.org trainings, and then if you scroll to 2023 trainings, in a couple of weeks, it will be up on our YouTube page. Let me just check to see if we have any more questions. Nope, we're good. So yeah, remember to please and thank you fill out the evaluations that come after this webinar, and it'll have the slides that went with this today too. Thank you so much for Dr. Dalby for walking us through this. This was amazing. I'm super excited to listen to the next one.
Thank you.
Thanks everyone. Talk to you soon.